settle in, let go of everything. I'm just checking in. And Terry's asked that we could hold a little bit of love and light for her friend who just transitioned yesterday, Sean Hoffman, and his wife Michelle, and their 2 children. So we can send some love and light their way. Recognizing that each of you has all that you need to be a rock star today. So, a little bit of housekeeping. I have these cards here that are gonna, I'll be holding up to keep you guys on track. So you have an hour, and this is how much time you have left, just so you know. Not what you've done so far. Only 5 minutes. So I'll hold those up for you just to kind of keep you on track. We have it structured so you have an hour to give your presentation, and then we have 15 minutes for questions and comments. And the way that we do it is everybody will go around and give a comment or a question or something, and all the feedback today is positive. And it's really helpful if you point out what you like, just to, because again, it's a learning experience. For most of you, it's the first time doing something like this. And so I really just want to acknowledge how the first time that I did something was that kind of in this realm was in front of, well, I guess not teaching, it was like in front of 300 something people. And so it was just like, oh, you're going to dive in. So it's really great that you have this opportunity to do this, you know, with supportive peers and such. I'm not sure what time any of the invited people are coming. So if people do come in, I'll make sure that they get what those kind of rules are. And when any of the level 3 people come, be it today or next week, I'm going to have a little short break to have you guys give the opportunity to talk to them a little bit about how level 4 was and what you think about level 4. Because as you know, level 1 has the most number of people, and there's an attrition rate, where a lot of people don't go to level 2, and a lot of people don't go to level 3, and then a lot of people don't go to level 4. And a lot of people don't actually really get what level 4 is, because there's no orientation. So it's you guys to help, you know, educate them on what it is or why they might want to do it. And each year we're looking to improve it. And I came back from Sitar, which I'll share with you guys probably next week about what's happening. I went to a meeting in the schools, what's happening with all the changes from with Sitar and IAYT. And I also just, having looked at your presentations, I encourage every single one of you, it's going to be in Newport Beach next year, I encourage every single one of you to submit and see if you can be a presenter. Because you all did so much amazing work, and you have great presentations that you could do there. And it's like, get your name out there, get out there, and that's why you kind of are doing this piece, right? So that you get that experience to go out there and, you know, represent LMU. And it's great. I've done it twice. It's amazing. It's such a great feeling. Paula, you've done Sitar too, right?
No.
Oh, I thought you did. Okay. No. Yeah, it's a great experience, and you really get to meet a lot of people that way. It's really good. So I encourage all of you to do that, and I'll be nudging you guys a little bit. So, without further ado, I'm going to introduce your next teacher today. So Elia, yoga therapy and depression. So welcome, Elia. The floor is yours. Where's make sure our phones are off.
Okay.
Do you want the door open or closed out there?
Okay.
Okay, whatever you want.
Okay, friends. So welcome. Thank you for your attention. And my presentation is on yoga therapy and depression. And I realized that talking about yoga to a bunch of experienced yogis, I'm not hoping to teach or convey any more about the practice or the tradition, but I'm hoping to impart something more about depression. And we all know depression, maybe the rough outlines of it. It's a word that is used commonly, and nobody's completely confused about what it means or how it might look. But what I'm hoping to do is maybe reveal some things that were revealed to me in the research of it that might surprise you in a big way about the mechanics of depression, especially. So, first we start with yoga. Okay. So this is an old chant. Oh. Are there any problems? Okay. So this is an old Vedic chant, and I think what would be good is if you guys close your eyes, and I'll do this too. Om. May it protect us both, guru and student, together. May it nourish us both together. May we both work with strength together. May our study have brilliance. May we not be antagonistic towards one another. Om, peace, peace. Feel free to open your eyes if you want. So the reason that I picked this chant in particular is I think that it speaks to every psychological fact, that it's not particularly theological or theistic. It's asking that we all participate and that we all learn and we study together, as you can clearly see in the first line. The guru and student have to be in a relationship, and that we're all students, more or less. So overview, just a little bit overview on yoga, and for the sake of linking it towards the end, and what the bridge that can be made with depression and the therapy thereof. So yoga began initially with the first text, considered the Vedas. I think this is an actual picture of the text, of the original text. And if I'm not mistaken, a lot of the Vedas were written on leaves. So they're very old. They were placed somewhere around 1500 to 1000 BC, although different experts differ in their opinion, in some places back as far as 5,000 years. And the Vedas really they're more artistic. They have religious, mythological implications, and they do also have some formulas couched in religious and theological terminology, but they do have what experts say are practical applications. So these are the 4 Vedas. I'll go into detail about those. What they speak to, and I think this is a nice point to make, is what Hinduism was originally called by the Hindus. Like, Hinduism isn't a term that Hindus developed. They don't call it that. So originally it wasn't a term like we are Hindu, it was just Sanatana Dharma. And what all of these teachings allude to is that there's just a single path. So Dharma meaning path or way, and Sanatana meaning eternal. It posits that the path and the way and Dharma is pre-existent, that there isn't a dharma that we create. It's an order, it's a way of being in the world that if we adhere to it, we're out to get best results. Okay. So after the Vedas, you have the writings of the Upanishads, and then the Bhagavad Gita, which all culminated in the text that yoga is most often attributed to and defined by, Yoga Sutras. And the Yoga Sutras talk about yoga, obviously. And just the typical definition of yoga is a uniting. It's the uniting of three aspects of our being, as you can clearly see in this picture: body, mind, and spirit, sort of to integrate the wholeness of the individual, of the embodiment. And this next picture, it actually came from more of a Western approach of understanding health. And it's called the triad of health: the chemical, physical, emotional. And you can see it's very, the link is nearly direct. So it's, I think that it's interesting. There's a lot of talk about how we try to stay away from Western medicine, and in some part that's true, but at the same time, health and what science is discovering about it, especially in recent times, has a lot of bridges and a lot of links to the original message of yoga, which is just a uniting of these different aspects of ourselves. So yoga is about chitta. So it's about consciousness. And this word is, it's kind of a catch-all phrase, I would say, for anything that designates attention. So consciousness can be something more perennial, internal, or it can be confined to one individual. So, I think what's valuable about yoga is that because it teaches how to be in the world and how to integrate ourselves into more complete individuals, it really sticks to chitta. And so if you think about this is the only thing worth valuing, is consciousness. In other words, consciousness is what makes value meaningful. Nothing can be valuable if there isn't something to understand that something is valuable. So chitta is the thing that is the most valuable, that is worth working for. And something that's become startlingly clear to me, over the years of teaching, is I remember in the beginning I always used to wrangle about how do I translate the sutras or the Bhagavad Gita to these people coming off the street that are just trying to get their sweat on, right? And so I would always, not butt heads, but I would always run into a dead end to where people get this glazed over look, or either I don't know what you're talking about, or I'm not interested. But later on, what I just saw is that we all value the same thing. No matter if you're a yogi, yogini, or if you're an alcoholic truck driver. Maybe not that case. But we all value the same things in life. We all want to be happy. We all want some sense of contentment. We want peace of mind, and we want to coexist in an environment where everybody supports everybody else. So, and this is what this concept of chitta really speaks to. The fact that what we value in life eventually comes down to consciousness. So from the Yoga Sutras, the point of the practice is to refine chitta in such a way, as seen from this verse 2, yoga chitta vritti nirodha, it is a a calming of the distractions that usually take our lives hostage from day to day. And usually the analogy that's given is water. So we have this rippled consciousness that there's distortions, and we don't actually get to see what we are in the end and at rock bottom, because we just can't break through the surface as is evident from water. You can't see the bottom as clearly if you have distortion, ripple up top. And so eventually the analogy comes down to making our minds more like this. To have clarity, to have equanimity. And this is what verse 3 speaks to. That when that happens, we behold our true splendor, our true grandeur, if you can call it that. I think it's just a neat picture to sort of symbolize that. And that's all well and good, right? It'd be great to make the consciousness, all clear water-like, but how the hell do we do it? That's the next question. So luckily, we've given a formula. Luckily, it doesn't look like this. Luckily, it looks more like this. Okay, so you guys are all familiar with this one. Okay, and there's definitely a lot to say about every single one of these limbs, but the focus of today is going to be specifically this asana, how postures apply to yoga therapy, how the concept of life force control via breath work applies to consciousness in yoga therapy, and meditation, the consciousness. I found that picture online, but then my girlfriend told me that actually looks like me.
It does.
Like me. Yeah. And this is something that I wanted to just include, because I spoke a little bit earlier about the whole the path of Sanatana Dharma, the concept of Sanatana Dharma as being this all-inclusive, I guess you can call it a formula that lets us grow and evolve and embody ourselves and potentialize ourselves. And a part of Sanatana Dharma is Ayurveda. And some say it actually came from the Atharva Veda, and commonly it's just referred to as the sister science of yoga. So it's the part of Sanatana Dharma, you can say, that applies to every other function of life, from what we drink, what we eat, how we breathe, the environments we spend our lives in. This is something you guys are obviously acquainted with. And so this is really kind of the application that I see that yoga really has. That it's not just the 8 limbs, it's really a way of including every single behavior you can see there: healthcare, medicine, that makes the project of yoga more complete and, I guess, efficacious. And I like the Ayurvedic proverb: when diet is wrong, medicine is of no use. When diet is correct, medicine is of no need. And that making a little link to Hippocrates, who's called kind of like the father of Western medicine, that his most famous saying is, "Let thy food be thy medicine," is an exact connection to what Ayurveda and essentially yoga and Sanatana Dharma to its roots. And this is also neat that Hippocrates acknowledged the fact that the ancients had something to say and they're worth listening to. Okay, so a little bit of defining depression. Okay. There's a lot of definitions of depression. I wanted to stick more to what is agreed upon in large part by medical practitioners in our current age. And this comes from the Diagnostic and Statistical Manual of Mental Disorders, the most recent edition. Okay, so the diagnostic criteria, basically how depression is diagnosed, is you have to have 5 or more of the coming up symptoms within the same 2-week period. So at least 5 of all these things. First being the most obvious, depressed mood most of the day, nearly every day. And a little bit of elaboration on that. Sadness, hopelessness, discouragement, absence of feeling, anxiety, things that we, I think, all know depression to express itself as. A loss of interest or pleasure in nearly all activities. I think this is a really key one. Feeling excessive or inappropriate guilt. What many depressed patients exhibit is a sense of guilt for their current state of depression. And because, as you'll see later, depression is oftentimes linked to other physical ailments. Patients will feel guilty about having that. Sleep disturbance. Okay. This is something, in even my limited experience dealing with, anybody that has depressive symptoms, insomnia is pretty much a given. And most people exhibit middle insomnia, which means just waking up in the middle of the night, not able to fall back to sleep. And then eventually waking up in the morning, not feeling fully rested. Okay. So as I said before, this is present in high proportion of cases. Fatigue is another big one. And I think this is an obvious extension of insomnia. If you're not getting enough sleep, fatigue is what you can expect. Also present in high proportion of cases. Usually they come coupled together. It's an interesting one. I think that with depression, people either overeat or undereat. So either people feel so sad and low and hopeless, they obviously have no appetite. For some people it expresses differently, where they try to fill the void, you can say, quote unquote void, with some enjoyable substance. And we're going to get to that a little bit later with the diet part. Psychomotor agitation or retardation. What this really just means is if you're fatigued, the way I see it, fatigue, sleep disturbed, this is going to affect your not just cognitive impairment, but your psychomotor impairment. So your motor skills are obviously deficient. As they say, you shouldn't be driving a car, at least for too long, if you're sleep deficient, like I did this morning, in that same way. Diminished ability to think and concentrate. So this is pretty much the mental aspect of psychomotor agitation. The aspect of suicide is categorized really in severe forms of depression, but it is oftentimes there, at least the thought of it. So even having a specific plan. Okay. So again, at least 5 of these must be present according to DSM within a 2-week period every day. You'd be classified under major depressive disorder. So major depressive disorder is, another synonym is clinical depression or just depression. Severe severity. So out of all the 9 symptoms that you saw, mild is considered 5 to 6 symptoms in mild severity, mild functional impairment. Moderate is pretty much 90% of all those symptoms. And the severe cases is pretty much 90% of the symptoms that you saw before, the diagnostic criteria, plus psychotic symptoms or suicide attempts and plans. Okay. Long-term depression, called dysthymia, is, as you saw, all the previous diagnostic criteria and symptoms, but they have to have existed for at least 2 years. So that's what carries major depressive disorder into long-term depression. Okay. In secondary diagnosis, I'm going to put this up briefly. I want to just go over it really, really quickly. The reason I wanted to put this up is because a lot of times depression comes about as an aftershock, you can say, to other disease or disorders. You know, people that have serious chronic ailments, people that are maybe at the end of their life, people that are in stage 4 cancer and they don't have much to live, much longer to live. Okay, they have depression, but it's not categorized as major depressive disorder because it's a result of something else. So it's secondary to something else. And the reasons are, you know, vast. So we're not going to go into that. I want to stick really to major depressive disorder. In saying that, as we'll see later, it actually begins to look like even major depressive disorder is always going to be secondary to something else. In other words, a person could never be fully functional, physically, psychologically, emotionally, chemically, and still have depression. That depression is an expression of something else going on beneath the surface. So at the end of the day, you know, I think it's interesting that depression really is a secondary diagnosis no matter what. And hopefully we'll get to see what that means. So, grief being one of them, it's obvious. The only distinction that is made with grief as opposed to just a traditional major depressive disorder is people that are undergoing bereavement actually have times of humor and hope. So they only express depressive symptoms in response to the people or beings that they lost. So these are just some of the sources where secondary depression traditionally, technically comes from. Those two go in a different order, but cancer, fibromyalgia, IBS, you know, the list goes on to what can bring about depression. Oftentimes you'll see people undergoing detox from drugs. They have depressed symptoms. And again, manic depressive disorder is something we're not going to go into, and it really needs careful professional examination. So with all that being said, it's interesting that depression, as you can see from the definition of a symptom here, I think begins to also look less like a disease in and of itself, but more of a symptom of other things going on. As you saw, as you remember that list of 9 diagnostic criteria. So depression is defined by those symptoms, which puts, at least as far as I see it, depression in the realm more of a symptom than an underlying cause. These are a couple of the self-assessment tools that are used to professionally given to patients to eventually give them a diagnosis or a lack thereof. And interesting thing to note about this and about the list of diagnostic criteria that we went over before is that it requires self-assessment, that the subject's individual take on their state is absolutely essential to the diagnosis. So it's not something like cancer where you can go about your life and you don't know that you have a tumor growing inside of you, and you need, some specified medical technology to let you know what your true state is. This is something that subjective assessment is absolutely essential in. So diagnosis that's absolutely essential to self-assessment, to the subjective assessment. Okay, so a little bit of the causes. Where does depression come from? Central factors. Just to give you a heads up, I named these things in such a way that hopefully later on in the presentation, something that I termed initially as central factors, may not look so perhaps central anymore. And peripheral factors. So one is genetic, and another one is functional and structural abnormalities, and that has to do with the central factors of depression, of the cause of depression, and then the peripheral factors have to do with lifestyle. Those lines are supposed to come in a different order. Can you imagine?
We don't know that. That's exactly right.
So, getting into genetics, again, I'll try to go quick about this because it's far outside my scope of skill or training. But I'd like to just start with what Stanford School of Medicine so far has, where they see depression and genetic etiology today. That 40 to 50% is attributed to depression, which means that, interestingly enough, that 50% of depressed cases are unrelated to genes. 50% is unrelated to genes. So if you think of, if something is not genetic, where else could it come from? And there have been some studies that, in adoption studies, where parents of offspring that had major depressive disorder, their offspring, even though they're adopted and never met their original parents, have a proclivity towards depression and or diagnosed major depressive disorder. And this is kind of like their final statement on the genetics of depression. We don't know the answer yet, so at least it makes me feel more at ease about presenting genetics of depression. So no one simply inherits it. There is, if I'm not mistaken, something like 20 to 25,000 genes in the human DNA. So we all inherit a unique set of genes, it just means characteristics, that can predispose us to something. And then we'll see later how we can actually activate our predispositions. Something that's obviously genetic is gender. So for whatever reason, females, women, statistically express 30-60% more susceptibility to depression. And personally, I think this has something to say about the fact that women are by nature more the feeling elements. So if you're, to me it makes sense that if you're more in touch with your emotions, and your emotions aren't in a clear place, you'll be able to react to that easier or quicker, or with more, maybe severity is the right word to say, than if you want. So this is again the current state of major depressive disorder. There's no single gene that we can say causes it. There are some diseases that they say are purely genetic. So there's some types of like muscle dystrophy, I think Huntington's disease, maybe Alzheimer's, if I'm not mistaken. Alzheimer's has also been attributed strongly to genetics. Okay, so this is going to get maybe a little bit technical. We're not going to focus on the technical part, but I just wanted to go over it to make a link to what's the information that's coming later. So some of the candidates for where genetically depression comes from has to do with the monoamines. So this is something that we hear a lot about. This is a series of neurotransmitters that we've all heard plenty about. Another one is BDNF, brain-derived neurotrophic factor, and stress hormones. So stress is going to be an interesting
area of depression to go into. And of course, pro-inflammatory markers, cytokines. Okay, so first, genetics and the monoamine system. Monoamines control many brain functions. There is a lot of hypotheses in what causes depression, and one of the major ones, the monoamine deficiency hypothesis, is that it is so far the most pharmacologically relevant theory, and most, and that means depletion of some or all three neurotransmitters, serotonin being the most extensively studied, and the serotonergic system, the serotonergic pathways being where most antidepressants, or what most antidepressants target. So serotonin essentially derived from tryptophan, which we get from food. Okay. 90% of our serotonin, they call them receptors, are found in the GI tract, and they're just basically our happiness and well-being chemicals. The gene that transports it has been relatively successfully talked about in research, and this is the reason why many antidepressants target serotonin pathways. This genetic susceptibility, you don't really need to know the numbers, has what it's susceptible to, or how it leaves individuals susceptible to depression, is with the occurrence of adverse life events. So in other words, the gene in and of itself will not make an individual, as far as is known, depressed unless adverse life events come into it. As I said, direct targeted antidepressants, SSRIs, okay, brain-derived neurotropic factor. Okay. And again, you don't need to know this gene, but so far they've talked about it a little bit. Nothing successful or conclusive has been made of it yet. The only thing that, maybe there's a couple things, but one of the strongest things is that antidepressants which target the serotonin system end up increasing hippocampal BDNF levels. And the hippocampus is something we'll get to see again soon. Stress, again, these are words you're going to hear repeated. Stress decreases what antidepressants increase in the brain, BDNF. Stress hormones, something I'm sure we're all well acquainted with, especially in the recent weeks. Okay. So the hypothalamic, hypothalamic pituitary adrenal axis, it's a part of the sympathetic nervous system, which is the initial engine and trigger that sends a cascade of stress hormones out. So the HPA axis is what reacts to stress. So the hypothalamus releases CRH, the pituitary gland releases ACTH, and then cortisol being the final product. Okay, the big bad cortisol. I had a psychology professor years ago that said they did stress studies on animals, and stress studies, as far as I've read, have been some of the hardest to read about when they test the limits of stress on animals and the things that they do to really find out how far you can push stress. Cortisol, being the end product, actually has corrosive properties on tissue. And what they've seen in some of these mice or guinea pigs or whatever animals is after they've passed on from the experiments of stress, their insides are virtually dissolved because of the corrosive properties of cortisol. So again, a little bit more kind of inconclusiveness is that people with major depressive disorder have so far should have written no evidence of dysfunction of that stress axis, the stress hormone axis. Environmental programming is something I mentioned before, so that's just another term for adverse life events, which is child abuse, you know, and you can imagine what else it could be. Stress, technically, scientifically, resembles a lot of how major depression expresses. Then cytokines being the main markers of stress response. They are the initial molecules that are involved in the stress response, released by the lymphatic system. They're also, I think they have some sites that produce it or release it in the nervous system as well, but by and large, it's the lymphatic system. The release of it resembles symptoms of major depressive disorder. So when you're under inflammation, you have a lot of the diagnostic criteria that we went over previously that has to do with major depressive disorder. So inflammation and major depressive disorder begin to look a lot alike. Okay, so part of it is fatigue, cognitive psychomotor impairment, appetite dysfunction. So when we're under stress, when pro-inflammatory markers get released, obviously this down-regulates our parasympathetic nervous system activity. And this, I think, is an interesting little fact that aspirin, because it's an anti-inflammatory, has been shown to have antidepressant effects. And that created more research kind of questions in immunology. This is a doctor that is kind of big in the genetic world of major depression disorder, mood disorders. According to him, no single gene is necessary and sufficient for major depression. Each gene susceptibility contributes just a small fraction of what causes major depression. And that environment really is the key that turns genes on. Okay, so functional structural aspects of where major depression can come from. A big one is traumatic brain injury, and the chronic version of that is chronic traumatic encephalopathy. Okay, so this began early on in observation of like veteran professional boxers. There is 4 million sports-related concussions that occur annually. Advanced TBI is consistent with reduction in brain weight, which is just neural degeneration. Atrophy of, again, if you remember, I mentioned already, the hippocampus, amygdala, thalamus, temporal lobe, a lot of which is the endocrine system and the stress response system. And so tears, it just has to do with damage to key areas that are implicated in major depression and stress. There was a study of 760 U.S. Army soldiers from Iraq. 700, so 9% of them reported TBI, 1/3 of which reported positive for a depression disorder. Symptoms of TBI and CTE are headache, cognitive impairment, again, if you can recall the initial diagnostic criteria for major depression, emotional ability, sleep disturbance, okay, behavioral disturbance, okay, and stage 2 and 3 of CTE, chronic traumatic encephalopathy, is exactly to do with major depressive disorder. And I think that it's interesting, the 4th stage of CTE is just over dementia. And I think it's a nice little, maybe way to entertain the fact that depression or mood disorder or psychological disorder is on a continuum, okay, where the last stage of it is dementia. So maybe it could look like depression is a precursor, that unintended to could turn to dementia. Maybe. So GABA, a neurotransmitter that is important in many other neurotransmissions. GABA hypothesis of depression states that low levels in the cerebrospinal fluid and plasma and the anterior cingulate cortex are considered mechanisms. They did a postmortem kind of dissection of major depression in individuals, and they found a downregulation of enzymes that produce GABA. Limbic system has all of these parts. Okay? The limbic system is basically our emotional part of the brain. The limbic cortex, and I'll talk about the limbic cortex a little bit more later. As you can see here, you have the hippocampus, the amygdala, the hypothalamus, which is the first branch of the HP axis that responds to stress. It's the feeling and reactive brain. The prefrontal cortex, and this is going to be the specific part of the prefrontal cortex that has been strongly researched and implicated in major depression etiology. The function of it is external mental context. Planning, strategy formation, executive function, receive strong inputs from all 5 external senses. Okay, so it's a very much out in the world part of the brain. Okay, part of the what's called executive network. So that's where we execute things. From where we execute things. And is it pregenual? Genual? Whatever. The P, anterior cingulate cortex, the PAC, okay, its functions are internal mental contents, mind wandering, random undirected thoughts, self-reference, interoception. So interoception as opposed to exteroception has to do with feelings kind of under the skin. So especially interoceptive regions. Because it has also inputs from all 5 external senses, it has been termed as the convergence zone between how we interact with the exterior world, the external world, and how we make sense of it with our internal selves. Part of the default mode network, so as in opposition to the executive network. Part of the limbic cortex, as you saw, part of the limbic system. So, in depression, there is an increase in the resting state activity in the PAC. So, that means that in depression, in clinical depression, there is an increased amount of action and stimulation in the part of the brain, the part of the limbic system, that's associated with internal processes, that's associated with interoception, with emotion, with brooding, rumination. And as I said before, it has links to being having a decrease in GABA. And it's implicated in other mood disturbances as well. I think it's interesting because mood disturbances, they do lie in a continuum, and that's what ended up kind of coming through, like all the reading that I was doing, that depression doesn't really lie in its own category on the outside of other mood disorders. It really is a part of a chain of events. Okay, so the prefrontal cortex has a decreased state of activation and function in major depression. So the part of the brain that's engaged with the world, with exteroception, with movement, with the senses, is underactive in major depression. Okay? And I think there's some research that actually found part of the prefrontal cortex is active in empathy. So that's an interesting thing to know. That's another part that it does. It plays an important role in fear extinction. Only 60 slides to go.
You get to choose which ones you want to use.
Okay. They done tests on the default mode network and the executive network, and they have a negative inhibitory relationship to each other. So I think they've done like transcranial magnetic stimulation, where they just basically put like a magnetic pulse against the prefrontal cortex, stimulating it, and show a direct inhibition of the default mode network. So the increase in one implies the decrease in the other. In other words, both aren't shown to be active at the same time, or inhibited at the same time. Two key leaders consistently implicating major depression disorder. This is something that's going to be important to get to. Autopsy studies, again, more autopsy studies, because there are ethical implications and liabilities with studying major depression disorder in live subjects, showed a consistent decrease of mass in the prefrontal cortex, the hippocampus, the amygdala, in individuals with dysthymia, long-term depression. Major depression disorder shows decrease of self-referentiality and self-focus, or increase, pardon me. So I talked about that before as a part of the PAC, the default mode network. So that's where people are detached from their environment. It's just called subjective experiential detachment. Neural asymmetry between the PAC and the DLPFC, so again, those outside and inside brain networks, is constantly observed in major depression. So this is where they are. You can see one is more external to the other. I think it's interesting that the executive network, being more external in the brain, is engaged more with the external world, and then the PAC, part of the limbic cortex, is more engaged, or is situated more under the superficial layer, the neocortex. So what does this all mean? So this talks about awareness. So it's a shift in awareness. That's where that's what major depression comes down to. So these are some of the peripheral factors. So this, lighting your computers, smoking out of your ears. Okay, so, and even our little ones feel it. So what does all of this have in common? Yay. Okay, stress. So don't have time to go over into the specifics of stress, okay? Although they are, all the specifics of it, all of the neurochemistry, the neuroanatomy of stress has virtually parallel links to depression. Okay, so just to kind of skip ahead, and just one slide to kind of I don't know if disenchant is the right word, but to maybe demystify or de-demonize stress a little bit. There is a scientist, he's like an Austrian endocrinologist. His name is Hans Selye, and he came up with general adaptation syndrome. So that's where the initial stressor creates resistance, where the body fights back via fight or flight response, and if the individual doesn't adapt and respond functionally, this will eventually aberrate to this, and so this being the key of stress and depression. So this is what we'll see makes depression what it is and has strong links to causing it. Okay. Can't avoid this little. So stress can be good. Stress can make our muscles big and our brains big, but too much of it can break us as well. Okay. So some of the other stressors that we can avoid. Some stressors we can avoid, many of it in our modern world. This is a map of just all the factory farms in the world, which I wish I had more time to get into. Okay, so stress being the key thing that eventually spurs major depression into existence, nutrition falls under the categories of stress. So our nutrition, our respiration or dysfunction thereof, or sleep and dysfunction thereof, and dehydration are the key elements that really stress out this whole physical, mental, emotional matrix that we are as humans. Okay. And I wish I had more time to get into all of the ways that dehydration, all of these stressors, how they cause depression or how they can cause depression. But skipping ahead, how much time do I have? Do I have time to go into my my interviews?
Yeah, please, yeah, do that. You have 10 minutes.
Okay. So the first interview that I did was with Jungian psychoanalyst Dr. Thomas Parker. So I asked how is depression defined in his school of thought. So he said there's two kinds. One is the subconscious. In Jungian terminology, the subconscious or the unconscious, I think they use the terms interchangeably, is termed as the shadow. So it's a part of our psyche that is implicit in all of our behaviors and thought processes and our personality, but we don't recognize it, we don't know it about ourselves. Okay. So once subconscious contents begin to be revealed to the conscious, and the individual doesn't know how to deal with it. So I think like the most simple way to give an example, an instance of that, is somebody that had maybe sexual abuse in early childhood, has blocked it out, and then later in life started to remember things that occurred in their childhood, and their inability to deal with it is one way that major depression or other psychological disorders can come into being. And he said most of the time it is a family and genetic issue. Okay, so let me get that to the big screen. What is a protocol for treatment for him? Because subconscious informs our thoughts and default state of mind, and again this calls back to the default network, changing thought behavior is imperative, as he said. Changing our thoughts. So, not brooding. You remember the PAC, the part of the anterior cingulate cortex that's in charge of internal processes, of rumination, of contemplation, interoceptive awareness, has to get changed. So his quote was, if you want to change depression, you have to change the way you're thinking. Most people do not know they're choosing their thoughts. And for yoga therapists, this is a big one. Okay. And dream analysis is another way. Okay. Protocol for treatment is physical exercise. That's what he says. Everybody, that's what he tells everybody. Get out and walk, do something, move your body. I always tell patients to get physically active, they need to move that energy in the body. I'd rather they do yoga than anything else. Okay. So, but no standard protocol other than analysis. Jungian analysis is directed by the subconscious of the patient, so any standard protocol really doesn't make sense because no individual is actually the standard, we're all individual. The prognosis of treatment is around 80% are treated successfully with psychotherapy, and I should have written with compliant psychotherapy. The prognosis without treatment, interestingly he said, about half of them cure themselves. And if he refers out, works in conjunction with anybody, if depression is so severe that normal activities are obstructed, he does advise short-term medication just to mobilize people to do something, to get out. Next interview is acupuncture.